My name is Stephanie Romano, and I'm one of the regional paramedic educators with Base Hospital. Thank you for joining us for one of our paramedic rounds via webinar. If you are new to the webinar process, you should be able to see a PowerPoint presentation in the background, and you'll hear a few of us with voiceover over top of the PowerPoint. You'll also see a control panel on your right-hand side. In that control panel, there'll be two useful tips for you. One is a hand that you'll see on the left-hand side of that control panel. If you happen to have a question and have a microphone and you're willing to actually use your voice to ask that question, you can click on that hand and we'll see that and be able to unmute you and you'll be able to ask a question. If you don't have a microphone or would prefer to type your questions, you do have a chat box at the bottom of that control panel. So you'll be able to ask us questions that way as well. Now feel free to ask questions throughout the presentation. We'll also open it up to discussion at the end of the presentation. If any of you are actually watching this as a group, or say in pairs, but only one person has logged on to the webinar, just send us a chat and we'll mark you both down for attendance to the webinar. So without any further delay, I'd like to introduce Dr. Mike Peddle, who's our Assistant Medical Director, and Dr. Matt Davis, who is our EMS Fellow, and your webinar on sports medicine.
Well, good afternoon. Myself and Matt are sitting here, and we're going to get into this. The first thing that we're going to put up there is a little bit of a disclaimer. Some of the information that we're both going to present to you over the next hour goes well beyond the BLS and ALS patient care standards. And so the key information for that is it's meant for you and to understand and know, but not to actually change your treatment and transportation decisions for those patients. So just remember that when you're sort of taking in some of this different pieces of information through the next hour. Hopefully by the end of this, we're going to be able to describe some of the pathophysiology of some of the sports injuries that we're going to present, recognize some of the key symptoms, and more importantly, some of the physical exam findings that we use in eMERGE. And then at the end of it, and I think this is probably one of the big things we want to talk about, is how to get some of these patients out of their equipment, especially sort of football, hockey type equipment, where changing how they get them out of that is important, because it's a little different than the stuff we do day to day in EMS and eMERGE. So the first thing we're going to talk about is ankles. I mean, ankles really are probably the most common lower extremity injury that we see in eMERGE. And the vast majority of the time we see them, they are just purely soft tissue injuries and they're not fractures. There's been some Canadian data that say about 3,000 people present per year, or per day, sorry, to Canadian eMERGEs for lower extremity sort of ankle injuries. The big problem with that is a lot of them end up with persistent symptoms. More than 40% can have persistent symptoms, and 80% of the time they can have a recurrent injury, so a second injury of the same ankle. And the downside to that is they miss work and or sport because of it. So we'll talk a bit about sort of the functional anatomy, so how does what the ankle is kind of made up of. And it really is kind of a ring-like structure if you want to think about it in a three-dimensional sense. Almost, or the vast majority of them tend to be on the lateral side, which is made up of the fibula and then the three ligaments sort of right on the front here, which is ATFL, CFL, and PTFL. So that ligament complex makes up the lateral side. The medial side down here is really your deltoid, which is a very strong ligament and rarely is isolated injury. Most of the time, if you're seeing a lot of swelling on that medial side, they tend to have another injury associated with it. And finally, we'll talk briefly about the syndesmosis, which is something not a lot of people talk about when they think of the ankle, and it's really the ligaments that join those two bones together. Like I said, most injuries take place on the lateral side of the ankle and of those three ligaments, and we grade them based on their stability and on the clinical exam, and that information also helps guide our disposition and management of the patient. This is the typical grading scale, and basically the key piece of information, especially from an EMS perspective is sort of this weight-bearing status. So the vast majority of the time, if you have a significant lateral ankle injury, they can't weight bear. They often look like they have fractures, and it's because they have pretty much completely disrupted all three of that lateral ankle complex. And so they tend to end up with pretty significant swelling, bruising, fair amount of tenderness and pain, and really are non-weight bearing from the time they injure it to the time they leave the emerge, and often leave on crutches because of it. The things that we want to do, both from a pre-hospital perspective, an on-field perspective, or in emerge, is the assessment stuff, which is looking at the alignment. How much swelling and bruising do they have? Where is a lot of their tenderness and weight bearing? Because that gives us an idea, like I've said in the previous slides, as to how what sort of class or grade of injury they are likely going to have if it turns out to be a soft tissue injury. Neurovascular status is key, especially if it ends up being not just a soft tissue injury but a fracture. And then mechanism, because then that comes into some of the other stuff that we're going to talk about as we go on about ankles, is that sometimes the mechanism is really the only piece of information that gives you something to consider when, with regards to a more significant injury other than just a lateral ankle sprain. Just to give you a bit of sort of continuation of care, what happens when they get into emerge after coming in with these injuries is, who do we x-ray? And I think this is important from a pre-hospital perspective, especially if you're sort of doing the on-field coverage for your kids' football or hockey or soccer games, as well as to understand what we do in emerges, why and who do we x-ray. We use the Ottawa ankle rules, which is kind of up on the screen here for you to see. It's kind of made up of whether or not they can walk or weight bear immediately and in the emergency department, and then 4 areas of tenderness. And those key areas being the back, sort of the posterior tip and 6 centimeters of the lateral malleolus or the fibula, the there we go, the medial on the same side right over the medial malleolus, and the TIF metatarsal, and on their navicular. So all they need to have is either tenderness in any one of those 4 spots or not being able to weight bear, and they need an x-ray to look at whether or not there is a fracture in that ankle or foot. So we'll talk a bit about PRICE. Everybody has heard or I suspect that everybody's heard the acronym RICE for what we do with ankle sprains, being rest, ice, compression, and elevation. I had an extra in there for P, and that's really for protection and physiotherapy. And this is another reason that a lot of these people need to end up seeing medical care for these injuries. Protection basically is some type of, not quite immobilization, but positioning, splinting. And what they found is that if you put people in splints, they actually do better quicker. So they get back to their baseline function faster, they have less pain associated with it, and actually have earlier return to their full range of motion and strength by putting them in a brace of some sort. And the big thing with physiotherapy is it actually reduces the chance of re-injury, so it takes that 80% chance of re-injury and reduces it, and significantly reduces the chances that they're going to have either persistent mechanical or subjective pain symptoms associated with their injury.
And just that physiotherapy, they work a lot on range of motion of the ankle early on, and then move into strengthening, but also proprioception. Just the mind's or the brain's ability to know the exact position of the ankle. And that tends to be a lot of the common cause of re-injury, is just the lack of proprioception.
Yeah, that's a great point. So this is one of these things that I wanted to talk about. It's not a common injury, but it is a significant injury, and especially something that we see around southwestern Ontario, given the amount of turf sport that's played, and that is the high ankle sprain or the syndesmosis injury. It is often missed by physicians, physiotherapists alike, because most of the time they actually will have a normal x-ray. There's no broken bones associated with it. There's some debate as to how often it occurs, but the evidence would say that it's somewhere between 1 and 11% of ankle sprains that show up in a sports clinic will actually be a syndesmosis injury. They are most common in turf sports, and that's because they are often a result of an external rotation in a planted foot. So the key with the turf sports is that you've got spikes or in your shoes that keep that foot planted when it gets hit, and so you get a rotation, an external rotation right around the ankle joint because that foot is kept in place by the shoes. And basically, if you can imagine here, it's basically this foot here gets planted, and then the tibia rotates inwards, and the foot stays planted. And often they'll have significant symptoms. They'll look like a grade 3 or a fractured ankle, but in all, their actual injury is in their syndesmosis. And really the only thing that helps you sort that out is their clinical exam. So I've posted 2 pictures here that basically give you how to assess for a syndesmosis injury. The first one here on the left-hand side of your screen looks at just reenacting the actual injury, and what they will have, they will describe pain right at that point where that arrow is pointing. They'll say that is where their significant pain is. The other one is the squeeze test here, where you just sort of mid lower extremity squeeze the 2 tib and fib together, and they will sort of describe the most of their symptoms and pain is right at that sort of syndesmosis. Most of the time, if you have other types of ankle injuries, they don't describe their pain in that one localized spot.
And often with ankle injuries, once we discharge them from the emergency department, I often inform the patient that you're going to have pain for the next 4-6 weeks in that ankle, but after about day 10, things should start going in the direction towards healing, so it should start to feel better. The pain should be improving. If they still have the same amount of pain at that time or increased pain, often we tell them to return to the emerge or follow up with their family doctor so that the syndesmosis injury can be looked for at that time once kind of the swelling goes down and the ankle can be assessed better.
So we'll move up the body a little bit here. Now we'll start talking about the knee, and ultimately mechanism is the key piece of information that you want to know. How did they go about injuring this knee? Because it'll give you almost all of the information that you need to know to sort out what their injury is. Certainly, in your history when you're talking to these patients initially, you want to know, did they have any pop or swelling with it? Did they feel like it was more of a twist or a hyperextension type injury, because it leads to different underlying structures being injured? The direct blow to the anterior tibia often results in sort of ACL type injuries, hyperextension, the valgus and varus stress injuries, so knee in or knee out, and then whether or not they're feeling like their knee is unstable or giving way, and whether or not it's locking. On the physical, some of the key pieces of information that you want to know is, do they have a big swollen knee? The inability to flex past 90 degrees comes into whether or not they're going to need an x-ray, and we'll talk a little further about which one of these, similar to the ankle, needs x-rays. The inability to straight leg raise, SLR straight leg raise, talks to whether or not they have a significant extensor mechanism injury. So if they've blown out their quads tendon or their patellar tendon, they won't be able to take their leg and straighten it all the way out by themselves. Joint line tenderness will sort of give you an idea of what side's hurting, and then as with all of our sort of extremity exams, we want to make sure that their neurovascular status is intact, especially when it comes to significant knee injuries where the nerves in the vascular tree run so close to the joint and are so key in part of it. I'm just going to give you a little bit, this is similar to the ankle rules. It gives you a bit of an idea of when they end up in a merge, or when we see them on the field, who do we decide really needs x-rays. Basically, if you're over 55. If you've got tenderness on the fibular head, isolated patellar tenderness, can't do that 90 degrees of flexion like we talked about, or can't take 4 steps, they are more likely to have a bony injury that is going to require either immobilization or surgery. And it's a pretty good study. The nice thing is that similar to the ankle rules, they've actually validated this in kids as low as 6. So you can use it in kids, though it's not quite as robust in that younger population. Going to move on and change gears a little bit and talk about those Charlie horses or muscular contusions. Kind of threw this in here because I think it's an important thing. We don't see it a lot, certainly in hospital, but we do certainly on the sidelines we see a fair number of them. And the big problem is not so much the contusion, but it's more when they get into myositis ossificans, which is basically when that contusion or intramuscular hematoma calcifies and you have a bunch of calcium or bone basically sitting in the muscle belly. The most common place for these to develop are in the quads or in the biceps. And there's a couple of key pieces of information that we would look for when we assess these people. First off being their neurovascular status distal to their injury. Maybe I can let Matt talk a bit about why the neurovascular exam is so important in these patients.
So with this, you get a lot of bleeding into a fixed space or a compartment. So what can happen is as the bleeding continues in that compartment, which is a fixed space, you can get further injury to the muscles, the structures within that compartment. This is known as a compartment syndrome, and it often presents with pain. The limb becomes white or pallor. They lose sensation in distal to that area. They'll also lose a pulse and will not be able to move the extremity which is involved. So that's kind of known as the 5 Ps: pain, pallor, paresthesias, pulselessness, and paralysis.
Yeah, certainly it's not a common injury with these contusions, but we have seen one actually not that in the recent past from a quads hematoma, so it certainly can happen. So that's why it's so important. We look at their range of motion to grade the severity of it. If you want to take, we'll use the knee or the quads as an example. So if they can flex greater than 90 degrees, then it's a mild contusion. 45 to 90 degrees is a moderate contusion, and if they only have 45 degrees of flexion or less, then it's considered a severe contusion. You want to always watch them for continued expansion and growth, which is one of the reasons they need to be observed, certainly if they're in that moderate to severe range, because you want to make sure that it isn't getting bigger and potentially running into neurovascular compromise. One of the key pieces of information when you look at that is whether or not they have a bleeding disorder, be it either congenital, so something like a hemophilia, or iatrogenic, where they're actually on like antiplatelet or warfarin or fragment type medications that results in them bleeding more excessively than otherwise. The treatment for these is key in that really it's still the standard rice and pain control, but there is some positioning, and as you can see in this picture here that I have on the screen, basically what you want to do is try and get that muscle out to length as much as comfortably possible. So this guy obviously only has a mild contusion if he's able to bring his knee all the way up that far, but he's icing it, he's compressing it, and he's stretching it out to length within tolerance. And the key piece of information here is positioning within tolerance, because you don't want to stretch them too much either. You don't want to have them actively stretching. You don't want to have them actively massaging it, which is something quite often people do when they get these, or heating it or being too overactive on it, because what that often leads to is more muscle damage, more bleeding, and a higher likelihood that they're going to end up with problems. The other key piece of information for these is to avoid re-injury. Certainly once you get into that moderate to severe contusions, if they take another hit during their healing process, some of the evidence would say that they have an up to 100% risk of developing myositis ossificans, which is quite a debilitating problem. If you've got a big chunk of bones sitting in your quads, it certainly limits function, results in more pain, and they can be difficult to treat after the fact. So this is another sort of common contact sport injury that we get into, but don't often see very often, but I think is reasonable for us to know a little bit about, and that's the burners and singers. Anybody that plays hockey, football, or probably most contact sports have probably had one of these in their lives. But basically it's just a traction on the brachial plexus, and they get sort of that numbness, tingling, and things can't really work that well in the arm. Often it's associated with some weakness in the, or paresthesias within that C5-6 dermatome and myotome. The assessment really is the key for these people. Generally, I guess I'd highlight the lower end of the slide first, which is if they have bilateral symptoms, so both arms are involved, if they have lower extremity symptoms, or they're complaining of C-spine pain or tenderness, then they need to be immobilized. That's not a simple burner or stinger, and they actually they should be immobilized and brought to hospital immediately. A simple burner will usually have no pain in their C-spine. They'll have normal pain-free C-spine range of motion, and often the symptoms in their arm will be made worse if they bend their neck to the opposite side, so lateral bending of their neck away from their sort of symptomatic arm. The management for these is most of the time they should resolve in 15-20 minutes, and if they don't have any of those high-risk things that we've talked about, and symptoms resolve within 15 to 20 minutes and they're back to their baseline normal, then there's really nothing else that needs to be done for them. Anytime they have persistent symptoms, they definitely require further assessment, and rarely they can last up to 2 weeks or more, and those require sort of significant sort of PM&R type follow-up. Like I said, if they're asymptomatic, they go back to their normal baseline neuro exam and they have good range of motion of their neck and shoulder without any problems, they can go back to playing at that point. So this is one of my favorite sayings when it comes to football, and for those of you who know me, they know that I'm a big football fan, and so I think this is come to highlight in football and hockey, especially over this last season. In both those sports, they've been doing a lot of talking about concussion and avoiding concussion and the problems associated with long-term concussions in these sports. So we'll talk a bit about it. I'm not going to read the slide to you, but all of this information here basically came out of the 2001 Vienna Convention, which is probably the biggest and probably the landmark changing concussion group, in that they changed a lot of how we view concussions and how we manage concussions. And I think the couple of key points to take from this is, it is from biomechanical forces that are applied either to the head through a direct blow or through transmission of forces through the body. So the key piece of information here is to remember you don't have to get hit in the head to have a concussion. You can get hit in the body, and if you're not prepared for it, you can still end up with a concussion-like syndrome after it. Another key piece of information to remember is you don't have to get knocked out to have a concussion. The vast majority of them generally don't. And whether or not you lose consciousness doesn't really play into the severity of your concussion syndrome. And finally, that it often takes a sequential course and over time to clear most of the symptoms that you are going to get from a concussion. I think this is the key thing that I like to remind people when it comes to concussions is, you can't ice your head, you can't wrap your head, you can't splint your head, you can't arthroscopically manage it, and certainly it can't be replaced like most other joints. So it really is one of these things where it is truly the sort of the rest and management that we talk about, and we'll talk some more about, that come key for the management of a concussion. The assessment, and I'm not going to read through these lists, but what I'm trying to get at here is basically there are a lot of different features that are associated with concussion, and there is no one solid feature that you have to be called a concussion. And I think, for those of you that follow hockey, this comes sort of quite clear when you look at the Sidney Crosby incident, where a lot of his symptoms are not things that we commonly associate it with concussion, but yet he still does have a concussion when you do the testing. So they can have things based in their signs, things that we can see or find on them. They can have cognitive features, like they're just being a little slow or not quite their normal selves, right up to confusion, and then lots of symptoms. And there's a myriad of symptoms that they can have, everything from headache to just being sleepy to feeling dazed, stunned, and visual changes. For anybody that does sideline kind of management or sort of football, soccer, anything where you can have a contact, this is probably a key piece of information to keep with you, which is the pocket scat card. And it goes over how to quickly, the pocket one is sort of the quick assessment tool for if you think they have a concussion, go over this card with them, and if they have any positives in 1, 2, or 3, then they should be removed from play and further assessed for a concussion. So I won't get too detailed into the assessment. I think the big thing that often isn't done, we often will talk about what their symptoms are, whether or not they remember where they are and what they're doing, but looking at their balance. And that sort of comes into this balance testing where you basically have them stand heel to toe on their non-dominant and look at how well they can maintain their balance for 20 seconds. And most of us can do this without too much difficulty. You'd be surprised at how difficult it can be, even in the mildest of concussion.
Dave, is there anyone there that has a question for us at this point?
Mike, Matt, waiting to see if anybody will put their hand up. I do have some typed in questions, though, that I've just kind of been sitting on for a minute. A couple things that you might want to address. First of all, in the emerge setting, do you have any preference for any pain medication that you would use on most of these patients?
Are we talking concussion, or are we going back further to sort of soft tissue injury of?
Sorry, going back to the soft tissue injury when you're talking ankles and arm stingers and that sort of stuff.
My preference is to stick with within the NSAID family, as long as there's no contraindications or problems with that. They tend to work better because they'll give some of the anti-inflammatory plus the pain relief. So yeah, I don't have a preference one over another, but I tend to stick within that family for sure.
I also tend to recommend the NSAIDs, and if it's not quite cutting it, then I tell them they can add in some Tylenol as well, as long as there's no contraindications to the NSAIDs, such as GI bleeds or allergies, then definitely the NSAIDs are the #1 medication that I recommend up front.
Connected with that, one of the medics wrote in, he wanted to know if pre-hospital pain control for some of the extremity injuries makes your job more difficult as far as assessing the patient once they arrive in ED.
No, I would say that definitely not. That isn't the case. If you have a significant injury that is there, single doses of medication to sort of make transport and initial assessments, including X-rays, more or easier done in the emerge department doesn't inhibit our ability to assess the patient and sort out their underlying injuries after the fact.
Okay. And sorry, just 2 more quick ones on extremities, and then we'll get back into the concussion end of it here. One medic was wondering about meniscus injuries, if there's anything that we have to be careful in pre-hospital to make sure that we don't aggravate them in any way. And another question is talking about how often are we seeing these injuries that have bad outcomes in the high school age population?
I think coming back to the meniscus injuries, there's really, I guess the one key feature is positioning of comfort. Most of the time, a meniscal injury is not going to want to be in a fully extended position nor in a significantly flexed position. And in those positions, it's going to be certainly more painful for them and a little more uncomfortable. So no, from that perspective, no, we're not going to put them in any significant injury. I guess one of the key pieces I tell people when they have a meniscal injury is that unless they physically go out and do something that would re-injure the meniscus, the individual positioning is not a problem. I guess one of the things that sort of would carry on down the line in that situation is more if they've got a locking meniscus. So rarely, sometimes when you get a large meniscal tear, you can actually lock out your joint. And in those cases, certainly trying to position them in anything other than the position that they're comfortable in could potentially aggravate or worsen their underlying meniscal tear.
And a key component for that pre-hospital, of course, anytime that we have any joint injuries, the direction is to splint in the position found. So that's what we would do, splint in the position found, and you're talking more the after effect and emergent ongoing care.
Mm-hmm. And I'm, my short-term memory isn't great, and I know you had a second question there that was following up on that. And what was that again?
A quick question about how many of these injuries that we're seeing in high school age population that have serious outcomes, and then I'll hold the rest of them till the end because they're coming in fast and furious now.
Oh, well, that's good. It's a tough question to answer, actually, Dave, because I don't work in the pediatric department. So certainly when we're at Vic, we don't see them from that perspective. Speaking from my previous or other life at Fowler Kennedy, we certainly see a lot of varied sports injuries from high school sports, including the most common ones being shoulders, heads, and knees, I guess, would be the big ones, and as well as ankles. And it's varied, I'd have to say, in the severity and difficult outcomes, because I think it depends, one, on their underlying injury and what that underlying injury was, and two, how quickly they come to assessment for us.
Great. Okay, so why don't we jump back into the presentation, and then a little bit later I'll have more questions for you. Or anybody who's listening, feel free to click on the hands up button and ask the question yourself if you like. Okay, thanks.
Sounds good. So we're getting back into it. This is the second part of the card. This is not the pocket card, but the full-on assessment tool. This is what we fill out on the patients at the sports injuries clinic. And I think hopefully we're going to try and move this into the emerge department as well and have them to start filling out this paperwork in the emerge prior to getting sent to the sports injuries clinic. It goes over some of the same things that the pocket card covers, but just in much more detail, including having them fill out a full sort of symptomatic evaluation. How are you feeling today? Some of the sideline stuff is really the same. Then it gets into the sort of the more detailed cognitive assessment. So can you remember like immediate recall, delayed recall, concentration tests, including like serial number exams or backwards counting are there as well, and then getting into delayed recall after that. Then there's another balance exam. It's slightly more detailed than the sideline balance exam. But I think one of the key things that I've always been impressed with is how often especially as they sort of recover, their underlying symptomatology is very mild. But when you do their memory assessment and then their balance assessment, how off they are, if you want to use that as the right term, and how much difficulty they have with those tests, even though from a just pure symptom management perspective, they feel like they're doing okay. And we will fill these out on a serial basis until they're back to what is a baseline. And baseline can be difficult. We like to, certainly at the sports injuries clinic, we like to actually have baselines on all athletes. So certainly at Western, with any of their high-risk sports, they all have to do neuropsych testing at the beginning of the year before and then we use that as their baseline for when they return to sports should they end up with a concussion. There's been a movement to do that within the minor hockey leagues with the Nike Bauer system here in London, and I think it's progressing, but certainly still isn't universal in all sports as much as it should be. I think this is probably one of the key slides when it comes to concussion, and one of the big questions that we get a lot of is who can go back to play? Like, if you think they may have a concussion, who can decide whether or not, or can you decide whether or not they go back to play in that same game or that same day? And I think the easy answer is that if they're adolescent or children, they're out. There's no return to play the same day until they're fully assessed. In adults, if their symptoms are mild, basically, they felt it, it's completely resolved. You do their SCAT testing and they pass their balance. You do some sideline run sprints in some kind of cardiovascular sort of exertion, and they don't get any symptoms back, then it's felt that they're probably safe to go back. But I live life by that bottom line there that, if I'm not sure, I sit them out. And that can be difficult, certainly in key games. And you're always put in positions as a team physician of deciding who can play, and it can be very difficult. But my final answer when it comes to that is it's easier to sit out one game than it is to sit out a whole season. And so I tend to sit people out when I'm not sure. Once again, coming back to what happens when you end up in a merge. This is very similar to the ankle rule, the knee rule. We have a rule for the head, so when do we have to CAT scan them? And I think one of the key pieces of information is that they need observation. When you look at a couple of these factors, it's based on observation for 2 hours. So are they at a normal GCS at 2 hours after the injury? Any physical findings associated with it being an open or compressed skull fracture, basal skull fracture, greater than 2 episodes of vomiting, and once again, age always comes into a lot of these rules as over 65. Those are the high-risk features, so things that likely will have some neurologic intervention needed. Medium-risk features are things that will have a CT finding that don't need anything necessarily done other than observation, and they tend to be significant amnesia or a dangerous mechanism. Like I said, the big thing with this is rest, and this has been a bit of a challenge for certainly sports medicine physicians over the last years. Is rest doesn't just mean physical rest, but mental rest, and so we will take kids out of school, we'll take the people out of work for a period of time for concussion management, purely because they need that mental rest. And the kids always get excited when they say we're going to keep them home from school for a couple of days, but unfortunately home from